Okay, we're going to talk a little bit about fibrotic lung disease. Most of you are reasonable at interpreting lung function tests from people with obstructive lung disease. And in those people with obstructive lung disease, you have certain cutoffs to say whether the disease is mild, moderate, or severe. But the numbers are slightly different with fibrotic lung diseases, and sometimes they've got these DLCOs and TLCOs and KCOs that start to get a little bit complicated, and that's why I'd like to talk about it now. One of the most common questions to come up in the MRCP are, when it comes to respiratory anyway, are differentiating upper lobe causes of fibrosis and lower lobe causes of fibrosis. And there is a very long list of those things that give you upper lobe, and a very long list of those that give you lower lobe. But what I've tried to do in drawing your attention to this right-hand box, in the right-hand boxes, these are things that kind of sound a little bit different, a little bit similar, but cause opposing either upper lobe or lower lobe fibrosis. So EAA and CFA, they kind of sound a little bit similar to each other. Remember that the C in CFA stands for cryptogenic. We don't know what the cause of it is. But an EAA, an extrinsic allergic alveolitis, that's about continual exposure to allergens, and you get a type 4 hypersensitivity reaction. Basically meaning when you breathe in lots of hay again and again, or mold again and again, or wheat, or cotton, or lots of other different things, you can end up with EAA. Now, conceptually, I don't know whether you're aware, but at the top parts of the lungs, as far as ventilation and perfusion goes, the ratio of ventilation to perfusion is much higher in the upper lobes than they are in the lower lobes. So you ventilate your upper lobes better than you do your lower lobes, partly because the weight of these upper lobes sit like wet sponges so that these bottom sections get a little bit squashed. Generally, things that you breathe in that cause damage to the lungs are generally going to cause more damage to the upper lobes than they do the lower lobes. And the exception to that is asbestosis, where those fibers, those little pointy fibers, are so fine they end up making it down into the bottom portions of the lungs. So things that you inhale tend to cause, so over here, silicosis, and the lower lobe is the exception to the rule, asbestosis. Things that you inhale tend to go to the upper part of the lung. And if I just get you to If I take you to turn to the reverse page and the bottom right-hand box, I can actually page down so you can have a look. EAA, where you're breathing in lots of allergens. TB, while you've breathed in a little bit of mycoplasma into your lungs in order to get TB. ABPA, allergic bronchopulmonary aspergillosis, you've breathed in little fungal spores in order to irritate your lungs. Those tend to occur on the silicosis. You breathed in silica dust, and that's caused fibrosis. So a lot of the things at the top of that upper lobe fibrosis box are things that have resulted from you inhaling stuff. Whereas looking at that bottom section, the lower lobe fibrosis, all of the connective tissue disorders tend to give you lower lobe fibrosis, as well as cryptogenic fibrosing. We don't know what it is that's causing that, and asbestosis, just because those fibers are so fine, they end up making it to the bottom part of your lungs. So that's why I just want, if you're not going to learn your upper lobe and your lower lobe list, and you're going to learn just a couple, just focus in on these, because those are the ones that are going to try and trick you out. Connective tissue disorders, rheumatoid arthritis, all of those generally affect the lower lobe, apart from ankylosing spondylitis. It's the only one of the rheumatological conditions that give you upper lobe fibrosis. Okay? Sadly, other than that, it's just a process of sitting down and learning them. This is a little lone alveolar sac, and this is a blood vessel that's going by. This, around the space, is the interstitium, the supportive tissue that holds that alveolar nice and open. And gas, in order to make it into the blood, has to be breathed down into that alveolar sac. To make it across the interstitium, I slightly over-exaggerated the space between the alveolar and the blood vessel there, but you get the idea. Make it across the interstitium and then into the blood vessel. So keep that in your mind. We have ways of measuring how good you are at getting air into your lungs and out of your lungs. You get somebody to blow, do those flow volume loops, and then you can see how air goes in, or you can get somebody to do a peak flow or do spirometry, and we can see how air goes in and out of a lung. We've also got tests in order to work out how well the lung absorbs the gases that are in there. Now, it'd be great to be able to measure how well the lung absorbs oxygen, but we have to use a surrogate, and we use carbon monoxide. We get somebody to take a big hoofing breath of carbon monoxide, and we measure the amount of carbon monoxide they breathe in, and then we get them to breathe out, and the less carbon monoxide comes out. And the amount of difference between the amount of carbon monoxide that they breathe in to what they breathe out, if they've absorbed lots, then their lungs are very efficient. If they've absorbed a little bit, then their lungs aren't very efficient. And we use that as a surrogate marker of how good the lungs are at absorbing gases. And that amount, that total amount of carbon monoxide that an individual can absorb in one breath is called the TLCO, total lung carbon monoxide. Now we're going to talk about things that increase, as an individual, my TLCO. Now, things that can increase it is if I were to have some inflammation in my little airways, inflammation, that's asthma. If I have early asthma, then little blood vessels are going to be exposed to that carbon monoxide that's been traveling through. And more carbon monoxide is going to be absorbed if I have asthma. Would you agree? Now, if I've got some horrible vasculitis, like Wegener's, microscopic polyangiitis, or Churg-Strauss, and I bleed into my alveoli and I have a pulmonary hemorrhage, there's lots of fresh blood that's hanging around and sitting right in that alveolar sac. And carbon monoxide is going to want to stick into this blood pretty quickly, and it will do that preferentially. So if I have pulmonary hemorrhage, then that's going to put my TLCO up. Now if I have, this is blood going by, and this is like a train picking up the passengers of oxygen or carbon monoxide going by. If I've got a hyperdynamic circulation, so that blood is being pumped through those blood vessels very, very quickly, then in that case, the blood that's being pumped through, increased cardiac output, would increase my TLCO because more carbon monoxide can be carried away. Agreed? If I'm polycythemic, I've got lots of red blood cells in there. Polycythemia will increase my TLCO. Now, in the same way, there can be things that decrease my TLCO. If I've got chronic lung disease, and it's difficult actually to get, these are narrowed, it's difficult to get the oxygen or carbon monoxide down into these alveoli, it's going to be reduced. If I've got muck and I've got a pneumonia and I'm now filling this with mucus, it's going to be reduced. I could fill this with liquid, or I could pack out lots of edema to separate the air that's coming down, or the carbon monoxide, from the blood vessel, and that's just pulmonary edema. If I got fibrosis in here, interstitial fibrosis caused by anything that gives me upper lobe fibrosis or anything that gives me lower lobe fibrosis, including all of the drugs that can, and there's a list of drugs on the reverse side of the page. If I'm anemic, or I've got a cardiac failure, a decreased cardiac output, now there are another group of things. What if I have got pleural disease? So I've got a pleural plaques. Or what if I've got a problem with my chest wall? I've got really bad kyphosis from ankylosing spondylitis. I've got myasthenia gravis, or anything that affects the musculature of my chest, so I can't take a big breath. Or I've got motor neuron disease. Or I've had a stroke, so it's difficult to get my diaphragms down. Anything that affects the mechanical movement of my chest means the smaller the breath that I can take, if I can only take a small breath, then my TLCO, small breath, equals a reduced TLCO. Would you agree? If I only can take half the size breath, then although I might absorb quite a bit of the oxygen, the carbon monoxide in that, I've still only taken a very small breath. Understand? This is a set of lungs. Now, I'm going to just make up some hypothetical values. And let's say my TLCO equals, I'm just making up an arbitrary number, 10. And then I get lung cancer in one of my lungs, and I have to have a pneumonectomy. I have to have a whole lung removed. And now I have if I look at the volume of the lungs that I had before, I had, let's say, 10 units. 10 units. Now I've had one lung out, and I've got a lung volume of 5 units. So what's going to happen to my TLCO? It's going to be reduced. And what number do you think it's going to be reduced to? To 5. So your hypothesis is that the TLCO is going to equal 5. Because you've halved your lung volume, then also the amount of carbon monoxide you should be able to absorb. Because I've got half the area to absorb it over, the amount that I should be able to absorb is half. Yes, you would think. But now my entire cardiovascular system, all of my blood volume is being pumped through one lung. Rather than having 2 lungs for it to go to, the heart is pumping all of the blood through this lung. So actually, I've got a state where one of my lungs has got an increased cardiac output through it. So that lung actually works more efficiently than it did before, because there's lots more trains going by that can pick up more molecules of oxygen for that given unit area of lung. So in this circumstance, actually what will end up transpiring is my TLCO is probably going to equal about 6. Let's say 6.5. Make it 6 for ease. Now if I work out what the corrected for my given volume So if I work out how many units of carbon monoxide is absorbed per given unit of lung, so carbon monoxide divided by lung space, this equals 1. Whereas the carbon monoxide over here divided by the lung volume is 1.2. So when I correct for the lung volume, actually this lung is working more efficiently than the lung that was above. And this is what TLCO, also termed KCO, is about. When you correct for lung volume, how well is the lung working? So this is a case where you end up having one lung, a pneumonectomy or even a lobectomy. This is a case where your TLCO goes down because you've had a lung out, but when you correct for lung volume, TLCO, also called KCO, you end up getting an increase. And these are the things that you end up being asked for or asked questions on when you're in your exam. Because everybody can work out what puts your TLCO down. Most of the things that put your TLCO down also put your DLCO down, but there are going to be a limited number of things that end up, although decreasing your TLCO, increasing your KCO. Now, what are these things? Any time that you chop out a section of lung, that's going to decrease your TLCO and increase your DLCO. And one last thing, any restrictive lung disorder that actually doesn't involve the substance of the lung will end up giving you a decreased TLCO and an increased KCO. Now, what are those things? If I got you and I put a belt around your chest, I put my foot on and I tightened it up really hard so it would tighten up like this, and then I asked you to breathe in, you go, and I asked you to breathe out, that is a restrictive lung disorder. I've imposed a restrictive lung disorder on you. So as we were talking about before, if you start with the brain, all the way down to the pleural lining of the chest, any condition that's involved from the brain to the pleural lining that doesn't actually involve the lung is a restrictive lung disorder that will give you a decreased TLCO but an increased KCO. And what I mean by that is if you had a stroke so that your diaphragms ended up really high, your lungs are normal in there. They've been squished into a really small space. You can only take a very small breath, but in actual fact, whatever you do breathe in, you're probably going to process quite efficiently. Understand? The same goes for after you've had a stroke, to if you've got a problem with the nerves, if you've got something like motor neuron disease, if you've got a problem with the neuromuscular junction, myasthenia gravis, if you've got a problem with the muscles themselves, if you've got muscular dystrophy, or even very severe polymyositis, the muscles aren't working very well. If you had bad kyphosis or kyphoscoliosis, where you squished your chest up, your good lungs, good big lungs, are squished into a really tiny little space, your TLCO will go down because you can only take little breaths, but the amount of that carbon monoxide as a proportion that you absorb is going to be higher. Chest wall deformity, pleural plaques, but then anything that involves fibrosis of the lung, causing your restricted lung deficit, where the kind of elastic tissue has been damaged and it's all tight and scarred and fibrotic, is actually going to start affecting the substance that is between the alveoli and the blood vessel. Is that clear? You look a bit confused there, Katie. Okay, what I will do is quickly do one more comparison. I'm going to have a big, massive strapping guy. This massive strapping guy is 6 foot 6 inches tall, big rugby player, and then I'm going to stand him next to this tiny little midget dude. And the tiny little midget dude, we're going to say he's got about as a lung area, make up some arbitrary units. We'll say we'll start with him with 10. He's got 10 units of lung space. This big strapping dude over here, when we add him up, he's got about 15 units of lung space. So the amount of carbon monoxide this guy can absorb is definitely more than the amount of carbon monoxide that this guy can absorb. Agree? He can play rugby, big strapping guy, lift weights. This guy lift much smaller weights and play rugby with a smaller ball. His total lung volume is 15 and his is 10. So let's talk about TLCOs. The total amount of carbon monoxide that this guy can absorb is probably going to be about, let's say, again, 15 arbitrary units. And the same with this guy, 10 arbitrary units. Let's say this guy now gets involved in a horrible car accident where his chest is really badly mangled. His lungs are still intact, but he's broken all of his ribs and his spine is all mashed up. And he's now all kyphotic, and he's squashed his lungs down into the same amount of space as the midget dude. So he's squashed 15 units of good lung tissue down into 10 units of space. The number of alveoli this guy has got is greater than the amount of alveoli this guy's got, even though he squished his lungs into a smaller space because he's got this really bad spinal disease. If you got him to breathe in, the amount of carbon dioxide his significantly more alveoli, but within the same space can absorb, he can only absorb 10 units. Now he's going to have a reduction from his 15 units when he was big and strapping. He's probably going to have a reduction, but he's probably now going to have 11 units in 10 units worth of space because those extra alveoli are going to buy him value. So there's been a reduction of his KLCO, but actually his TLCO has gone, his KCO has gone up. So his TLCO, his total amount has come down. So if you divide 15 by 15, it's 1. But if you divide 11 by 10, it's 1.1. You've had an increase in the efficiency of the lung. It's totally not as good, but over the given area, it's better than the midget down here. Is that a bit easier to understand? Have I just confused you further? Okay.
TLCO and KCO
Exactly the same, just different terms for the same thing. K for corrected or constant. So this is the last one. We're just going to go for the take-home points. Obstructive lung disease causes a low FEV1. This is from a different topic, and it also causes a low ratio of FEV1 to FVC. Restrictive lung disease causes a low forced vital capacity. So actually the amount I can breathe out, if I got a belt around my chest, I would take a breath in and I breathe all the way out. That forced vital capacity, the amount I can force out in life, is actually very small. So forced vital capacity reduces with restricted lung defects. Hyperexpansion on a chest x-ray. You've seen these before, haven't you? The diaphragm's really low down, really long lung fields, and this tiny little diddy heart that's hanging. Hyperexpansion on chest x-ray, along with a high total lung capacity, so if you were to measure it in a chamber, that total lung capacity, and high residual volume, that means when you breathe out, I can't breathe out all of my lung volume. That's emphysema. If you were to remember only a couple of little ones of upper lobe versus lower lobe fibrosis, EAA causes upper lobe fibrosis, whilst CFA causes lower lobe fibrosis. EAA is just extrinsic allergic alveolitis caused by inhaled allergens, and it's the type 4 delayed hypersensitivity reaction that causes repeated damage, long-term damage to the lungs, and therefore fibrosis. TLCO, which is otherwise known as KCO, corrects for the lung volume. Ground glass appearance on CT scan suggests that the lung fibrosis may be steroid responsive. And this is something that you see quite frequently. You know, somebody comes in, they've got some dodgy looking features, they say, I'm getting progressively more short of breath, they've been on some nasty agents for treatment of some rheumatological disease. You end up ordering a high-resolution CT scan, and the long and the short of it is you're looking for ground glass appearance. If there's just honeycombing and scarring, there's no point giving that person steroids. It's not going to stop their fibrosis. It's already there. It's already scarred. But that ground glass appearance are neutrophils that are filling the interstitium and sometimes even the little alveolar sacs. And if you use steroids, you can calm down the immune system, and those neutrophils aren't going to cause quite so much damage, so you might not get fibrosis that's quite so bad. So ground glass is an indication that the patient is going to be steroid responsive. And the last point on that, take-home points, is normal left-sided atrial pressures are required to make a diagnosis of ARDS. Pulmonary capillary wedge pressures, all that means is increased atrial pressure. And that's left atrial pressure. If you've got a high left atrial pressure, that means you've got left-sided heart failure. Because the blood's not being pumped out, it ends up backlogging and the atrial pressure goes up. Pulmonary capillary wedge pressure was just a very clever mechanism that somebody found, where you could feed a catheter down the internal jugular vein into the right atrium, into the right ventricle, into the pulmonary artery, blow up a little balloon, and if you wedged that properly into one of the pulmonary arteries, then the pressure that you would get distal to that balloon would be the same as that it would be in the left atrium. So it was just an indirect way of being able to measure what the left atrial pressure was. And if you've got pulmonary edema secondary to a high left atrial pressure, that's just left-sided heart failure. The reason that you've got edema squishing out is because the pressures have got very high in the pulmonary vein, and the hydrostatic pressures have increased such so that the fluid just leaks out into the lung. So to have a diagnosis of heart failure, you rarely need high left-sided pressures. Therefore, your pulmonary capillary wedge pressure was also high. Now in ARDS, which is adult respiratory distress syndrome, that's where you ended up getting pulmonary edema, which wasn't anything to do with the heart. You just had toxins that were circulating, damaging, you inhaled nasty gases, you were in a fire, you had inhaled water, you'd been resuscitated, and that had damaged the membranes within the lung. So the membranes became leaky and you ended up filling your lungs with fluid. So in cases of ARDS, by definition, adult respiratory distress syndrome, your capillary wedge pressure would be normal, because you're saying that the reason that I've got problems with my lungs is that the membranes are damaged rather than my pressures are very, really high.
How do you make a diagnosis for someone who's got background?
With much difficulty. As you treat their heart failure, they still carry on getting worse. The patient gets so sick they end up on ITU. When they're up on ITU, you end up doing a pulmonary capillary wedge pressure and find out actually that the left heart pressures are fine and their lungs are short. That's how you would end up making it. Okay, last question, guys. A patient attends a respiratory clinic with symptoms of dyspnea, shortness of breath, on exertion. He has a past history of ankylosing spondylitis with moderately severe joint disease. Results of recent investigations are as shown. The FEV1 is decreased. The FVC is decreased. So they're both decreased proportionately to each other. And when you look at the FEV1 over FVC, that's actually increased. So this person doesn't have an obstructive lung disorder. They haven't got an obstruction like putting your hand over your mouth. It's taking a long time to get out your lung volume because you've got an obstruction to it. You're actually getting out all of your lung volume in a pretty short period of time. That's your FEV1 over FVC. When we looked at the TLCO was decreased. The total amount of gas that this man could absorb was decreased. Yet his TLCO or KCO, corrected, was actually increased a bit. You're required to interpret these results and choose the following statement that is most accurate. This patient has a restrictive lung deficit, most likely caused by lung fibrosis secondary to ankylosing spondylitis. Well, no, this guy hasn't, because if you have a look, his TLCO is decreased, but actually his DLCO is corrected for his lung volume, is actually increased a bit. So if he had lung fibrosis, interstitial lung fibrosis, both his DLCO would have gone down and also his TLCO would have gone down. This is somebody whose TLCO has gone down, but his DLCO has gone up. So this is a problem either stemming from the brain all the way down to that pleural lining. Something is causing a restrictive deficit that is not affecting his lung. B, although he has a restrictive lung defect, the substance of his lung is unaffected by fibrosis, and this is true. If he had fibrosis, both the TLCO and the DLCO would have gone down. In this case, his lung volume has been compressed so that he can absorb less carbon monoxide, but his lung is working more efficiently, so his just as big, good lungs are being contained into a smaller space. Pulmonary hemorrhage in normal lungs would cause similar carbon monoxide transfer abnormalities. No. If you had a pulmonary hemorrhage, both your TLCO would go up and your TLCO or KCO would go up. So both values go up. If this patient had ARDS, his pulmonary capillary web pressure would be high. No, his pulmonary capillary web pressure would have to be normal if he had ARDS. His pulmonary capillary wedge pressure is high if he's got left ventricular failure. E. The distribution of lung fibrosis in ankylosing spondylitis is very similar to that of cryptogenic fibrosing alveolitis. Ankylosing spondylitis is usually the upper lobes, similar to extrinsic allergic alveolitis, but as we can see down here, cryptogenic fibrosing alveolitis affects the lower lobes. So no, that's false there. So the correct answer is, although he has a restricted lung defect, the substance of his lung is unaffected by fibrosis. So that's the end of the mini lectures. I know you were starting to fade towards the end there. I was starting to feel as though I was fading.